Rheumatoid arthritis. This is a brief clinical consultation. Mostly what happened that the patient has complained. What complaints come with the pain and the tingling in her or his finger, early morning stiffness of the hand. These two things are the more common in the patients coming with the rheumatoid arthritis. Then what the history you will ask, you tell me, and then I will come to that. So in the history, what will I will ask that, starting with that, you have to tell the patient, can you show me the where is the pain? So you have to start by questioning and also at the same time looking at the hand also. So you have to ask where is the joint pain. You have to look for the distribution. Typically it is symmetrical, it is involving both the hand. Then you have to ask about how its day-to-day activity is affected. So that is quite important, how he or her is affected by this. And you have to look for any complication is developed by that or not, such as carpal tunnel syndrome is the one of the complication. You have to ask about the early morning stiffness, how long it persists, it is symmetrical or not, if it is more than 60 minutes it is there or not. So these things you have to ask. Also you have to ask that if the patient is taking any medications, is continue or discontinued. This is the criteria for the rheumatoid arthritis diagnostic criteria. So you have to look at this, and it should be 6 or more than 6 to diagnose the rheumatoid arthritis, in which the number of joints, type of the joint. If it is a small joint, you will give the more weightage. If it is more than 10, it is 5, but if it is 4 to 10, it is 3, and then small, so more points if it is a small joint. If the large joint, it is less point, even if it goes to even 10. So okay, and the serology, what you will look for, you will look for the ACPA or anti-CCP, you also can call, and the rheumatoid factor. Two things you have to look. If it is negative, 0. If it is positive, how much it is positive, low positive or high positive. So it is low positive, you will get 2. If it is high positive, you will get 3. Other things is you have to talk about the acute phase reactants such as CRP and ESR. If any of this is positive, means it is normal, then it is 0, and if it is abnormal, then 1 point. And duration is also important. So whenever you are taking the history, you have to ask that since how many weeks this patient is having. Less than 6 weeks, 0 point. If more than 6 weeks, it is 1 point. So in the last, if it is 6 or more than 6 out of 10, you got rheumatoid arthritis. If not, then we have to think something else. Okay, here we will assess. When we will tell the patient to show the hand, we have to look at the where and what is going on here. Okay, so we can see here that the distal phalanx, it is not that much involved. It is quite well in the condition in the both half the hand, and is symmetrical also. Looking at the proximal interphalangeal joints, you can see that there is swelling. This is quite swelling. Swelling is there in both the hand, and also some deformity. We will come to that deformity later on. And also there is metacarpophalangeal joints that you can see here. That is the knuckles also. That is, there is swelling also there. So these swellings are there. You can look at the thumbs. It is quite very much deformity is there. We can say it is the Z form deformity, and there is other deformity also there. So we will talk later the different type of the deformity. Okay, so what happened, why we assess? We have to assess every finger to find out that's what is going on. As you can see here that this is the finger joint here. In the rheumatoid arthritis, mostly it is proximal interphalangeal joint is involved, and you can see that there is the thickness of the synovial membrane, excessive synovial fluid, and degraded cartilage. So when you will feel it, it is a boggy swelling that is so feel from the sidewise, also anteroposteriorly. So you have to feel the every joints, and mostly this is proximal interphalangeal joints, and also MIP joint is the most important. Also you have to look for the other deformity as well. Okay, so let us talk about the deformity. So this is the botinier deformity. What is the botinier deformity? You can say that's proximal interphalangeal joint that is flexed okay, and this is extended, and this is also extended. Is it right? So you can see that here there is a flexion deformity on proximal interphalangeal joint. Again, saying we already talked about botinial deformity. Here we can see there is the flexion deformity on the proximal interphalangeal joint. Here we can see another deformity, that is we call the swan neck deformity. Here is not the flexion but is a extension. That proximal interphalangeal joint there is extension, but the distal is the flexion. So this is the difference. This is called the swan neck. It is flex, it is extend, right? Okay, thank you. So while the examination, what other things you will look for? You will tell the patient to make a fist. He is able to perform that or not. You have to look for the rheumatoid nodules, whether it is present or not. So mostly in the extensor surface and mostly on the elbow joint. You have to, around that there will be there. Also look for the other things may be associated, such as gougertrophy, that is also cause of the other form of the joint problem. And surgical scar you have to look for. Palpate the all joints, that I already said. If there is tenderness and bulky swelling is there, it's mean the arthritis is active. Move to determine the functionality and do buttoning, unbuttoning, and picking the coins. These are the important things you have to tell. So here we already talked about that the DIP, distal interphalangeal joints, mostly spared. Other joints are involved. Ulnar deviations can be there in the MCP. Botinier deformity and swan neck deformity can be there. The Z thumbs deformity, piano key, ulnar head. These are the also things. Rheumatoid nodules, you will find surgical scar. What kind of the surgical scar you can find? There is the carpal tunnel decompressions, then there is other forms, Swanson's, arthroplasty, wrist arthrodesis, ulnar styloidectomy, and the wrist synovectomy. These are this type of the also scar you can find out. There is a long list of extraarticular manifestations. There can be hematological, like anemia can be there. So you have to look for the conjunctiva, for the any pallor there. Splenomegaly, that is the Felty syndrome, that is rheumatoid arthritis plus splenomegaly plus neutropenia. Skin, there is a nodule, vasculitis, pyoderma gangrenosum. Eye, you have to look for the scleritis, episcleritis, scleromalacia, perforations. So these are the cardiovascular. Also there can be pericarditis, valvular disease, and also MI there is chance. Heart failure also there can be. Respiratory, you will find pulmonary fibrosis also, pleural effusions, lung nodules, bronchiolitis obliterans. These are the extra other finding in the lungs. Renal amyloidosis. Neurological, peripheral neuropathy, mononeuritis multiplex, compressions neuropathy. Compression neuropathies include cervical myelopathy, that's you have to look for, and the ulnar neuropathy, elbow involvements, carpal tunnel syndrome. These are the investigation you can go through, such as CR, PSR, FBC, WBC count. Also you have to rheumatoid factor, serial antibodies you can look for, and associated several disease, increased mortality and extra-articular manifestations due to nodule if it is there. Also there will be anti-CCP we will do. So these are the tests we have to do. Other investigation, there's many other, like we have to go for the X-ray of the hand, X-ray of the chest. Also we can do the Doppler to look for the active synovitis also. Lung function test we will do. Also we will look for the pulmonary function test and HRCT, that can be also we can do. Here are the treatment options. So first you have to educate the patients, exercise, physiotherapy, occupational therapy, modification of homes that can be needed, and mobility and dexterity aids can be given, and pharmacological treatments. Early intervention is really important. We start with the NSAIDs, COX-2 inhibitor, DMARD, methotrexate, sulfasalazines, leflunomide, hydroxychloroquine. Old drugs such as gold and penicillamine, nowadays we are not using this drug nowadays. And the biological agents what we use, that is the TNF blockades, infliximab, adalimumab, golimumab. These are internacept, citralizumab. New biologicals therapy, rituximab also with, then adaticept, tocilizumabs. These are the drugs we are using nowadays also. Okay, in the next session we will go through some of the video clips and also look at the examination also, so how we can do.